Hello, everyone. Thank you for coming to this lecture on the social determinants of health and lifestyle medicine. I'm Gautam Ramesh, and this lecture was made in collaboration with your Health Equity Thread Director, Dr. Weena Joshi. This is one of your final lectures in the first year thread, so congratulations on making it all the way through. I have no disclosures, and I would like to acknowledge some of my past mentors, supporters, educators, and inspirations. So the learning objectives for this lecture are, firstly, what are healthy lifestyle choices? What exactly is good diet and exercise? And to what extent can they prevent disease? Secondly, what factors influence these choices? How are they determined? And when do people have a choice? Are they really choices? Thirdly, who is most affected by these factors? As we know that when things are unfair, they are unfair to the most marginalized people in our society. And finally, whose responsibility is it? Is health doctors' responsibility, government's responsibility? Is it the industry's responsibility, or does it land upon individuals? As medical students, most of us are interested in diseases. So let's take a look at those first. The top 10 causes of death in the United States are listed here. And you can see that cardiovascular disease and cancer are the top two, followed by unintentional injuries, lower respiratory diseases, stroke, Alzheimer's, etc. So we know what diseases are present in the US, but what causes these diseases? If we take a look at the study, the State of US Health, published in JAMA 2018, we see that the number one risk factor for death in this chart is diet, followed by use of tobacco, hypertension, obesity, high fasting plasma glucose, high cholesterol, low renal function, alcohol and drug use, air pollution, and low physical activity. This is similar for disability, and diet is number one in both charts. So when we ask the question, what causes diseases, it's behaviors that propagate these. Number one is dietary risk factors. In order to make a healthier society, we basically need to think about how we can reduce all of the things in the chart on the previous slide. So we want to reduce use of tobacco, reduce hypertension, reduce cholesterol, reduce alcohol and drug use, and we'd want to increase physical activity and increase the quality of our diet. This needs to be a priority for all stakeholders, not just on the volition of patients, but physicians, nurses, hospital systems, policymakers, and health insurance companies. To improve dietary intake at local and national levels, we can create financial incentives for healthier food, both for agricultural producers and food manufacturers, as well as the retailers and the consumers. This is something that can be implemented across the board in schools, workplaces, etc. Broadly, we know that we need to improve our physical activity and improve our diet while decreasing tobacco use, blood pressure, cholesterol, and alcohol and drug use. The EPIC Potdam study aimed to quantify exactly how much we are reducing our risk of chronic disease by following healthy lifestyle considerations. They identified 4 healthy lifestyle factors in the study of 23,153 participants, aged 35 to 65 years. These are non-smoking, a BMI of less than 30, physical activity of more than 3.5 hours per week, and a diet index greater than median. Participants who followed none of these 4 were adjusted to a hazard ratio of 1. From there on, they did all of the different combinations of these 4 lifestyle characteristics and analyzed what the reduction in hazard ratio was. So for participants who were only non-smokers but had a BMI above 30, did not have sufficient exercise, nor a high-quality diet, you can see that already there was a reduction in the hazard ratio for chronic disease by 33%. If we go on to participants who only had a BMI less than 30 but were smokers, did not have sufficient physical activity nor a high-quality diet, we can see that their hazard ratio for chronic disease decreased by 57%. Again, they went through all of the different combinations of these 4. Just to show you another example, for those who had greater than 3.5 hours of physical activity per week and a high-quality diet, but had a high BMI and were smokers, they had a reduction of their hazard ratio by 58%. For the participants that were able to follow all 4 of these healthy lifestyle characteristics, their hazard ratio was down to 0.23, which means that they were able to reduce their risk of chronic disease, namely cancer, diabetes, myocardial infarction, and stroke, by 78%. So what were the conclusions from the study? The participants who followed all 4 healthy lifestyle considerations had a 78% lower risk of chronic disease. Divided up by disease, they saw that for diabetes, it was a 93% reduction. For myocardial infarction, 81%, for stroke, 50%, and for cancer, 36%. And the 4 considerations were a healthy diet, physical activity of greater than 3.5 hours per week, a BMI of less than 30, and a non-smoker status. So now we know that, especially for chronic disease, the vast majority can be prevented by proper behaviors. So it's likely that poor behaviors are what are causing these diseases. This leads us to the definition of lifestyle medicine, which is the use of evidence-based lifestyle therapeutic interventions, such as diet, physical activity, etc., as a primary modality delivered by clinicians trained and certified in this specialty to prevent, treat, and often reverse chronic disease. So oftentimes when you're looking at lifestyle medicine, you'll see this chart with 6 segments. These 6 segments are increasing physical activity, healthful eating, managing stress, forming and maintaining relationships, improving sleep, and avoiding risky substances. So to summarize, what are healthy lifestyle choices? A healthy diet is first, high in fruits and vegetables. Then comes moderate to vigorous physical activity greater than 3.5 hours per week, maintaining a healthy weight, and being a non-smoker. If you do all 4 of these things, you have a 78% lower risk of chronic disease. When you compare that to common pharmaceutical therapies, these only decrease your risk for chronic disease, especially cardiovascular and cardiometabolic disease, by 10 to 25%. So hopefully that puts in perspective the power of these healthy lifestyle choices. Yet only 3% of Americans actually do all 4 of these things. We saw that diet is the #1 risk factor for both death and disability in the US. And some other facts that you should know is that a healthy diet could save nearly $1 trillion and could save 1/4 of all deaths globally. The food system is responsible for about 30% of greenhouse gases. And so for environmental and human health, restricting or eliminating red meat is one of the best things we could do. In conclusion, make sure you talk to every single patient you see, recommending that they eat more vegetables, more fruits, and reducing their red meat consumption. But oftentimes when we're counseling our patients, we might come across like this. So that begs the question. We know the vast majority of these chronic diseases are determined by behaviors, but what determine these behaviors? There are numerous ways to look at the different factors that play into lifestyle choices. Here I've divided up into intrinsic and extrinsic factors. The intrinsic factors are biological factors, so tastes, inclinations, lethargy, as well as mental and psychological conditions like eating disorders. This also takes into account handicaps, disabilities, genetic diseases, all of these factors that play on the inside that could be affecting how a patient is able to follow a healthy lifestyle. Also, we have conscious desires. So if someone wants to go and eat Taco Bell or McDonald's, that's a conscious desire that is pushing them towards perhaps a less healthy lifestyle choice. There's a lot of interplay between biology and conscious desires, and I've just divided them up here so that we can discuss them separately. In extrinsic factors, we have circumstance and institutions. Circumstance includes family and home. So this is your upbringing. Was your family nomadic or static? What were the family values? Did you have a strong parental presence? Were you in childcare a lot? Do you have any trauma? Were you a foster child or were you homeless? As well as what were the relationships like between you, your siblings, your parents and guardians, etc. Also the environment, urban planning, the air around your home, the public spaces available. Under community, we have the safety of your community. Is your community conducive to healthy choices? Do you live in a food desert or a food swamp? Do you have access to native foods? Socioeconomic status is another powerful player here. Did you have housing and financial stability growing up? Do you have housing and financial stability now? Are you able to pay for healthy foods? Are you able to pay for a gym membership? And then finally, time. How much time do you have to cook for yourself or exercise? Do you have restrictions due to work? Do you have kids or parents you're taking care of? Under institutions, we have education. So this can be elementary health education. We have culture and religion. So this includes your regional food habits, cultural practices, any dietary or activity restrictions that you have. We also have businesses and organizational interests. Marketing, cigarette ads, the tobacco lobby, for example, TV ads, as well as targeted marketing, such as race targeting or age targeting. If a lot of this is prevalent where you live, you are more likely to make lifestyle decisions along those lines. Finally, law and policy. What subsidies does your government provide for the agriculture sector? What are the dietary guidelines that are made? Is there any de facto structural oppression? So, when we see all of these different factors at play that can affect someone's lifestyle choice, we have to be empathetic and know that maybe this person's lifestyle choices are not totally in their hands. There are so many factors that could be influencing whether they're able to exercise every day or eat a healthy diet or cook for themselves. So keep that in mind when you see a patient who's not following these and try to work through their obstacles with them. Identifying these factors and addressing them one by one is one of the best ways that we can help our patients make better lifestyle choices. So here's the roadmap for the rest of the lecture. These are a lot of the factors that were presented in that spider diagram before. Firstly, we'll be talking about food insecurity and home cooking, then pollution and city planning, then family and home. Towards the end, we'll be talking about media and advertising, and finally, society and policy. And after that, we'll discuss some solutions. With each of these points, I'll try to include a few questions that you can ask your patients, so that even though this is a lecture on social determinants of health and it might seem more theoretical, we'll make it clinically applicable for you to apply during your ACA, during your 3rd and 4th year rotations, and further along as a clinician. All in all, we can see that diseases are caused by a number of lifestyle behaviors, which are influenced by countless factors. The first one we'll discuss is food insecurity. This is a graph that was published in Health Affairs in 2015 that plotted the percent of people who are food insecure in the United States every year. We can see that there's been an increase over time from 2001 to 2013, and there was a marked increase in the 2008 recession. We can also see that households with children are more likely to have food insecurity than households without children. Furthermore, if we look at the effects of food insecurity on children and adults, a whole host of things can happen, especially to children. This includes increased risk of some birth defects, anemia, lower nutrient intakes, cognitive problems, anxiety and aggression, a higher risk of being hospitalized, poorer general health, asthma, behavioral problems, depression, suicidal ideation, and worse oral health. Among non-senior adults, we also see mental health problems and depression, as well as diabetes, hypertension, hyperlipidemia, worse outcomes on health exams, being in poor or fair health, and poor sleep. And these are just the effects of food insecurity and the inability to obtain food regularly. Food insecurity affects millions of US households every year. Food insecure individuals face disproportionately higher rates of chronic diseases such as diabetes and HIV, and therefore accrue more healthcare costs. So this puts into motion a cycle of disease and expense that furthers the disparity between food secure and insecure patients. Coming back to trying to prevent these diseases, we know that behaviors cause diseases, and in this case, the behavior we're looking at is a poor diet that is caused by food insecurity. Now, a number of factors can be at play here. For example, obesity can be caused by food insecurity that can separately cause disease. Psychological distress can also cause obesity. We know that unemployment and disasters can cause food insecurity, and they can also independently cause poverty. Incarceration and pretrial custody can cause unemployment and can also cause poverty. High housing costs, high healthcare costs, lack of access to SNAP programs, these are all things that could play a role in causing food insecurity, which can then lead to a poor diet, which can then lead to a plethora of disease. So one solution to this is increasing access to SNAP, which is the Supplemental Nutrition and Assistance Program, because this has been shown to reduce the prevalence of food insecurity and thereby critical to reducing negative health outcomes. We can also increase affordable and accessible fresh produce in all of our communities. As medical students, you may have seen this in action through the graduate school and the Food Pantry and Food Recovery Network program, where they are combating food insecurity among graduate students. Diving a little deeper into how food security can cause obesity, we know that low food security is associated with obesity because of the high-calorie palatable food that is consumed by low food secure populations. It's also associated with obesity because of the limited time, knowledge, and resources that low food secure populations generally experience, and thereby creating some inability to engage in healthful eating and exercise. If we look at those with low socioeconomic status, we see that they have a higher energy intake, a lower resting metabolic rate, and a low activity energy expenditure, all which can lead to a positive energy balance or increased fat storage that we see clinically as obesity. Those with high socioeconomic status do not have these changes. There's no chronic change in their energy intake, nor their resting metabolic rate, etc. And so then there's no change to their weight. And so they are less likely to become obese. So since socioeconomic status so strongly affects health, that makes it so that health is not just a medical issue that should be dealt with by doctors. Health is a policy issue. And policy is a medical issue because it so strongly affects the health outcomes. So some questions that you can ask your patients are, where do you get your food? Walk me through your meals in a day. Has there ever been a time when you did not have enough food? Are you ever unable to purchase food? And what do you do when you don't have food? And these are fairly open-ended questions that can get the conversation going so that you can identify whether your patient is experiencing some sort of food insecurity. If food insecurity is the reason that they are unable to follow a healthy diet, then you've found the reason for their suboptimal lifestyle behavior. You've noted that it's not really a choice in their case, and you know what could be causing their disease. And so now with the cause in sight, you can identify how to best help your patient. Next in this first segment of the roadmap is home cooking. And there are a number of different things that can affect whether you are likely to be cooking at home, some of which are non-modifiable and some of which are personal factors. These include your culture and ethnic background, any health conditions you have or a high BMI, how much time and resources you have, your gender, the household you're currently in and the household you grew up in, close personal relationships, and a number of others. This can lead to a number of positive outcomes, including a lower BMI, dietary benefits, and both of these lead to health improvements, and there's interplay between these factors as well. One of the main reasons that people decide to cook at home is because they have a desire to save money, which highlights the importance of price when it comes to food. Time was another important resource because if you don't have enough time to meal prep or plan your meals, then you're not going to be able to cook as much at home. People with restrictions on time or working longer hours were less likely to cook frequently, and if you're employed or if your children have a lot of after-school activities, those are also obstacles to cooking at home. If when you were younger you had caregivers or personal role models that were cooks, then you're more likely to have healthy food preparation techniques. Both low socioeconomic status and high socioeconomic status were associated with greater cooking, most likely because of the ability to save money and also the requirement of needing time in order to cook more. Lastly, it's more likely for immigrants, especially Asian Americans, to cook at home. So some questions you can ask your patients to evaluate their current home cooking and likely to cook at home in the future are, what did you eat growing up? And where did you get your food from growing up? Do you enjoy cooking? Do you feel like you have the time to cook? What are some things that would enable you to cook more? If you're able to elicit from the patient things that they themselves have identified would enable them to cook more at home, you're one step closer to being able to help them save money and improve their health through cooking at home. Now, the second major topic we're going to be covering is pollution and physical activity. And there's a lot of interplay between air pollution and physical activity. It really is a two-way street. On one side, there is a huge risk-benefit trade-off in exercising in polluted air, which we'll discuss later. And we should also keep in mind the air pollution concentrations in locations of physical activity. We know that if we had more people walking and cycling for their commute, we would be able to reduce air pollution overall. On the flip side, a lot of polluted air can reduce overall physical activity levels and especially reduce physical activity during days that have high pollution. We know that air pollution can decrease lung function, elevate blood pressure, and exacerbate other cardiovascular and respiratory symptoms. All of these will lead to an impaired exercise capacity and performance. Visible air pollution, like smog that we see in big cities, can especially discourage people from engaging in outdoor activities. So those living in the areas with highest concentrations of air pollution are most likely to have lower levels of total physical activity. This is a graph that was published in 2021 based on data from the WHO database on air pollution. Essentially, it's trying to identify at what point there is still a health benefit of physical activity in a polluted environment and at what point the risk of air pollution outweighs the health benefits of physical activity. So on the x-axis here, we have the cycling time, and on the y-axis, we have the background PM 2.5 concentration. This is an evaluation of the particulate matter in the atmosphere. So the tipping point, the purple line, is the point at which increasing your physical activity no longer has a health benefit. So you can see when there is a higher PM 2.5 concentration, increasing your physical activity is not going to yield any more health benefit. So for example, on this graph, when the PM 2.5 concentration is around 150, exercising any more than 30 minutes is not really going to create any new health benefits. Now, the orange line is the break-even point. So this is when the risks of air pollution outweigh the health benefits of physical activity. Again, if we look at 30 minutes of exercise, if the PM 2.5 concentration is at around 100, the risk of air pollution is already outweighing the health benefits of physical activity. Now here we see that the average background PM 2.5 concentration is around 20 to 25. This means that it's more than likely that you can cycle up to 400 to 500 minutes per day before the risk of air pollution being greater than the health benefits of physical activity. What I want you to take away from this graph is that there does come a point where doing physical activity in a polluted environment does not have health benefits and can potentially have health consequences. So when you're recommending your patients to engage in more outdoor physical activity, you should also ask them about how the air pollution is in their neighborhood. So what are other environmental factors that affect someone's level of physical activity? This comes down to city planning, where an increased access to parks, improved neighborhood walkability and greenness, rurality, and decreased air pollution are all directly associated with an increase in physical activity. So modifying the attributes of the physical environment, namely the neighborhood walkability and the greenness of the neighborhood, may promote changes in physical activity. Studies have shown that increasing the roadside tree canopies can reduce air pollution and suspended particulate matter, reduce the ambient temperature, and improve the pavement longevity since they're less exposed to direct sunlight and heat. Things that encourage walking around outdoors include well-kept sidewalks, pedestrian priority, and public transportation. In fact, better than pedestrian priority on sidewalks is pedestrian overpasses, so that pedestrians are much safer when it comes to interactions with cars. Finally, we see that improved walkability of neighborhoods and the closer local parks are, the more daily steps and daily moderate to vigorous physical activity increases. So again, as medical students, we're interested in diseases, and we saw that behaviors are what cause these diseases. In this case, low exercise is able to cause a variety of diseases, and low exercise could be caused by a polluted environment. And there is interplay between these, where lower exercise can increase automobile use, which can then increase pollution more, which then again lowers people's inclination to exercise. Lack of trees and greenery can both increase pollution and can decrease people's inclination to exercise. Less access to exercise areas and public recreation spaces can discourage exercise, and pollution can directly cause disease or cause global warming that can cause disease. So some questions you can ask your patients are, do you live near a park? Do you have access to safe recreation spaces? How walkable is your neighborhood? How's the pollution in your neighborhood? The third section of factors that can influence lifestyle behavior that we're going to cover is family and home. We know that parents' diets and food parenting practices strongly influence children, and parents' role modeling and creating a healthy home environment increases physical activity and reduces sedentary behavior and screen time. So behaviors that the parents follow are behaviors that they can consciously and subconsciously pass on to their children. Family meals and social interaction during these meals are linked to the child's weight status and the development of their eating patterns. Children with mothers with a high education level consumed more fruits and vegetables than children with mothers of low education level. And cumulative exposure to television food advertising, which is notably higher in groups with lower socioeconomic status, is linked to subsequent fast food consumption as adults. So moving on to section 4, I know section 3 was really short, but I was just excited to get to the media and advertising. Research shows that television ads for food and beverage directed at children predominantly promotes unhealthy foods. And this is something that we've all seen, especially those of us who have grown up in the United States, where television ads show us a lot of sugary breakfast cereals, fast foods, candy, etc. To make matters worse, people with low socioeconomic status are exposed to more cumulative TV food advertising over their lifetime, and this increases their fast food consumption as adults and decreases consumption of fruits and vegetables, and this causal link has been very well studied. Furthermore, African American household income is 33% less than the income of non-Hispanic white households. So this increases the sensitivity to cost of basic goods and services, including food. And since low-cost foods are relatively higher in fat and sugar, those who are more sensitive to the cost of foods are more likely to be consuming foods that are high in fat and sugar. Marketing environments of African American consumers are less likely to support the development and maintenance of healthy eating, and this can lead to excessive caloric consumption and relatively poor dietary quality. African American consumers also have less access to supermarkets and more access to fast food outlets than their non-Hispanic white counterparts. And they experience a number of constraints based on place and price, since they may have limited mobility, limited work flexibility, and limited incomes. If we look specifically into the influence of television, African Americans have greater exposure to both targeted and non-targeted marketing because they have a higher use of media in general. Lower socioeconomic status, as well as being African American or Hispanic, are independently associated with longer daily TV viewing time. African American and Hispanic youth are an attractive market segment for child-oriented food markets because they have distinctive consumer characteristics, and this includes their spending patterns, media use patterns, and influence on the broader youth culture. So although targeted marketing seems obviously unethical, there have been some legal approaches to restricting racial and ethnic marketing, but it hasn't worked for tobacco nor alcohol, and so it's not likely to work with food products. Some people even say that if you reduce your targeted marketing, it might seem like a form of discrimination, since nearly every minority group has some sort of marketing targeted towards them. In both cases, the approach may be viewed as paternalistic. Finally, given that African American children and teens watch more hours of television than their non-Hispanic white counterparts, overall, the African American children see more food ads per day than their white counterparts, which can play a huge role in their health outcomes. As African Americans are more likely to live in racially segregated neighborhoods, from a history of racial zoning ordinances and much, much more, this can lead to geographic targeting. One example is how in Hispanic neighborhoods and low-income neighborhoods, you see more unhealthy and obesity-promoting retail food outlets. You'll see fewer large chain supermarkets and grocery stores, and many more fast food restaurants and smaller stores like convenience stores that may have their profits depending on sales of sugar-sweetened beverages and high-calorie snack foods. Now, the worst part is that in neighborhoods with higher minority populations, children and adolescents are more likely to be subjected to outdoor advertisements at schools, libraries, recreation centers, and the majority of these are advertising unhealthy products. We can't talk about advertising without talking about the incredible advertising for tobacco over the last century. Here we see a number of different advertisements that target psychological aspects that can influence smoking behavior, such as doctors themselves smoking or saying that there is scientific evidence supporting smoking. On the bottom left here, we see that these people who are smoking are having a good time and they have friends and significant others. On the bottom right here, we see that one cigarette company is saying that their cigarettes have less nicotine, which I guess means that their cigarette is less bad than the other cigarettes. But regardless, all of this marketing is trying to convince consumers to smoke more, which we know is bad for our health. If we look at the history of smoking, in 1950 we saw the first association between smoking and lung cancer, which was confirmed in 1954 with a 40,000 patient 20-year study. In 1964, the U.S. Surgeon General's report suggested this link as well, but the American Medical Association withheld endorsing this report after they got a $10 million gift from the tobacco industry. In 1966, we finally started seeing health warnings on cigarette packages, and in the 1980s, after a huge burden of respiratory disease and cancer, tobacco companies began to claim contributory negligence, which is basically saying, oh, the consumers should have known better. Finally, in 1998 is when health authorities no longer supported this position of the tobacco companies. If we look at the progression of smoking from 1970 until 2011, we see that there is a great decrease both in the number of current smokers as well as the per capita number of cigarettes consumed. From 1965 to 2006, there is a reduction from 42% of the population smoking to 21% of the population smoking, which is a great reduction, but keep in mind that a large fraction of the population still smokes. There is a paradox here when we see that African American youth have a lower prevalence of smoking, but African American adults have a disproportionately higher burden of tobacco-caused morbidity and mortality. This could be because of a higher availability of little cigars and cigarillos in African American communities and lower prices and greater outdoor advertising in minority and young adult neighborhoods. These can establish environmental triggers to smoke among groups susceptible to initiation, addiction, and long-term negative health consequences. There's also genetic variation in the MRGPRX4 gene that contributes to the inter-individual and inter-ethnic differences in the preference for mentholated cigarettes, which is another huge market that can be targeted. In terms of outdoor advertisements, they were 70% higher in predominantly African American neighborhoods than in predominantly non-Hispanic white neighborhoods. And there are 2.6 times as many tobacco advertisements per person in African American areas. There is a lot of targeted marketing when it comes to cigarettes. Cigarette brands have names such as Rio, Dorado, and American Spirit that are directed towards American Indians, Alaskan Natives, and Hispanics. The tobacco industry has also specifically targeted African American communities through their campaigns that use urban culture and language to promote mentholated cigarettes, and tobacco-sponsored hip-hop bar nights with samples of these mentholated cigarettes, as well as mailing promotions directly to people's homes. Tobacco companies also target Asian Americans by sponsoring Chinese and Vietnamese New Year festivals, having billboards and in-store advertisements in predominantly Asian American communities, financial contributions and support of Asian American business associations as well. So we know that diseases are caused by poor behaviors, in this case, a habit of smoking. So what are some solutions in this case? Well, we need stricter policies controlling how harmful substances like tobacco and alcohol are allowed to be advertised. We need to restrict race-targeted and age-targeted marketing, as nearly all minority populations are disproportionately affected. We need to restrict marketing in schools and children's television programs of unhealthy foods, because that can have an effect later on in life. And we need to clearly identify harmful ingredients in consumables such as cigarettes, processed meats. And in some countries, we already see this happening, but not so much in the United States. Finally, the fifth section of this lecture is the society and policy factors that affect people's health and ability to follow lifestyle behaviors. Now, there's a very short list of FDA-approved claims that companies are allowed to make in order to promote their goods. This includes the association between calcium, vitamin D, and osteoporosis, between sweeteners and dental caries, between lipids and cancer, as well as lipids and coronary heart disease, fiber and coronary heart disease, fiber and cancer, fruits and vegetables, soy protein and cancer, folic acid and neural tube defects, sodium and hypertension, and then finally stanol-sterols and coronary heart disease. But we see so many health claims on packaging that are either not supported by the FDA or have a very, very tenuous link. For example, on this box of Cheerios, we see that you can reduce your cholesterol by 10% in 1 month with Cheerios, or by 4% in 6 weeks. I don't know how they're able to make both of these claims, but this is likely coming down to fiber and coronary heart disease. Now, the Cheerios I ate as a child had less than 1 gram of soluble fiber per cup of cereal. Usually I had at least 2 cups of cereal for breakfast, and when you have 12 grams of sugar per cup, that's 24 grams of sugar in breakfast. And when the recommended upper limit for sugar is 36 grams for men and 25 grams for women, just from breakfast, you're coming dangerously close to these limits. If we look at the back of the packaging, we see that Cheerios says that 3 grams of fiber may reduce the risk of coronary heart disease. And at 1 gram per serving, you need 3 servings. And if I know how to do math, which I may not, this comes out to 36 grams of sugar. So you might have a reduced risk of coronary heart disease because of your increase in fiber, but that amount of sugar is definitely increasing your risk for endothelial damage and resultant atherosclerotic cardiovascular disease. Here's another one, that this organic whole milk supports brain health. So the total fat in 1 cup is 9 grams. The saturated fat is 5 grams. The cholesterol is 35 milligrams and sugars is 12 grams. When I was little, I used to drink 3 cups of milk a day, and this comes out to 27 grams of total fat, 15 of which are saturated fat, and 16 grams is the upper limit that you should be having. And there's no safe amount, but 16 grams is the upper limit. 105 milligrams of cholesterol, and cholesterol is a completely unnecessary component of diet, and 36 grams of sugar. So again, this may support brain health, which is not an approved claim by the FDA, but with that level of saturated fat, cholesterol, and sugar, you may be increasing your risk for coronary heart disease. Here we see how things like butter and cholesterol have been depicted by magazines in the last 50 years, where there's encouragement and then discouragement and then more encouragement, where you're not really sure what kind of decision to make. So most consumers will just be like, well, what the heck? Can't be that bad. But that is exactly the problem. The reason I'm showing you all of these advertisements and claims that are made in magazines is because this is where patients are getting their health information from. They're being educated on what is good for them to eat by the packaging on the food they eat and the media they consume. The general public has not received formal medical training, nor are they trained to read long research papers and clinical trials. And given how little health education there is in elementary, middle, and high schools, who are they supposed to turn to when they're looking for factual health information? Is disease prevention the responsibility of patients themselves? Is it our responsibility? Is it the responsibility of parents while bringing up their children? Is it the responsibility of schools? Is it the government? Is it the companies and businesses that create these claims? And whose responsibility is health education? Is it the patient's responsibility to educate themselves through information on the internet? Is it our responsibility to counsel patients in what they eat and how they exercise? Is it parents? Is it schools? Is it the government? Or is it businesses? Research from the Journal of Nutrition published in 2010 showed that 90 to 99% of young adults underconsume fruits, vegetables, legumes, dark green vegetables, orange vegetables, and whole grains. These are the components of a healthy diet, and nearly everyone is underconsuming it. Whereas 97 to 98% of young adults are over-consuming fats, sugar, and alcohol. These are classically the least healthy components of a diet. Nearly the entire US population is under-consuming the healthy components and over-consuming the less healthy components. If we look at this data published in 2019 in The Lancet, we see again that vegetables, fruits, whole grains, and nuts are way under-consumed by the American population, while red meat, starchy vegetables, eggs, and poultry are far over-consumed, from 200 to 700% of the reference dietary intake. So why are we as a population under-consuming fruits and vegetables? This could be because of food swamps. So food deserts are areas where food is not widely available, but food swamps are areas where there is a high concentration of unhealthy dietary options. Even after controlling for food desert effects, food swamps have a positive, statistically significant effect on adult obesity rates. This could be partially because inner city grocery stores have low profit margins, high overhead costs, and consumers who have less time and knowledge for home cooking, like we spoke about earlier. And since they have access to cheap and processed convenience foods, they're more likely to eat those. This is a major social determinant of health. There's a low availability of fresh produce and a high concentration of fast food outlets in these food swamps. When they're combined with few recreational opportunities, you can imagine why the lifestyle behaviors are suboptimal. To make matters worse, the price of groceries in urban areas is 3 to 37% more when compared to suburban residents. When you pair this with low socioeconomic populations, as well as African Americans having lower access to automobiles, it makes it more and more difficult for these individuals to achieve a healthy diet. So the stores that are around where someone lives are very important. There are 3 times fewer places to consume alcoholic beverages in the wealthiest neighborhoods compared to the poorest neighborhoods. On the flip side, there are 4 times more supermarkets located in non-Hispanic white neighborhoods when compared to African American neighborhoods. When we look at the characteristics of the food itself, research has shown that taste is the most important factor that people cite when selecting what food they should eat. This is followed by cost, nutrition, convenience, and finally weight control. People are more likely to eat something because it tastes good rather than not eat it because it would help them control their weight. Furthermore, people would more likely eat something that costs less rather than something that costs more because it is healthier. This is the trend for the general population, but especially for those who are younger, who are women, who have lower income, and who are non-white, they are more likely to rank cost as number 1. This highlights that especially for minority populations and those who are most affected by health inequities, it is important that we have low-cost, healthy foods. This is exactly the purpose of government subsidies that make it less expensive for farmers to produce their food. A cross-sectional study published in JAMA in 2016 showed that over half of the calories consumed by the general public are from the major subsidized food commodities. This includes corn, soybeans, wheat, rice, sorghum, dairy, and livestock. Unfortunately, even though these are the major subsidized foods, these are not the healthiest foods that people could be eating. In fact, a lot of these things are processed into less healthy foods, such as corn syrup and snack foods. This makes it so that consuming these subsidized commodities and products that are made out of these subsidized commodities can lead to a higher BMI, increased adiposity, increased inflammation and non-HDL cholesterol, and poor glycemic control. So why is the government helping pay for food that directly increases our risk of cardiometabolic disease? This goes back to a history of how the government has been supporting the agricultural sector over the last 100 years. In 1920, we saw the first agricultural assistance programs. In 1973, we saw the Farm Bill, which was created in order to increase the supply of food in general at reasonable prices. Unfortunately, current subsidies are still the same as those back then, paying for corn, soybeans, wheat, rice, sorghum, dairy, and livestock. Now, agricultural policy is what dictates production, and subsidies and providing money to produce certain things will encourage farmers to produce those things. And when those things are processed into high-fat meat and dairy products, refined grains, soft drinks, high-calorie juices, these subsidies are directly supporting the creation of unhealthy foods, which then lead to adverse health outcomes. So tackling policy that affects food production and food availability is the most widespread preventive measure we have to address the obesity epidemic. This is especially important in the United States, where 80% of our food is grown domestically. However, when we sum the output of the entire US food system, we are supplying 24% fewer servings of fruits and vegetables than are recommended for our public. In order to meet the dietary recommendations, Americans on average need to increase their daily fruit intake by 132% and increase vegetable intake by 31%. This is especially difficult in an environment with the following subsidies. We see almost $117 billion over the course of the last 25 years towards corn, nearly $50 billion to wheat, and $45 billion to soybean. And even though we know that tobacco consumption in any shape or form is bad for us, we have seen over the last 25 years $1.9 billion of subsidies, government money paid for by taxpayers, that have gone to the tobacco industry. Now compare this with something that is relatively healthier, apples, which have received $262 million in subsidies. So especially when over half of American calories consumed are from subsidized commodities, it makes sense why we're not eating so many fruits and vegetables, when fruits and vegetables are not the things that are primarily subsidized. So this has shown us how policy translates into subsidies. Subsidies dictate agricultural production. Production dictates consumption. This is just simple supply and demand. And you are what you eat. And if you're eating a lot of these subsidized things, which over half of Americans' calories are, that is going to lead to cardiometabolic disease, which eventually leads to loss of life and increased healthcare costs. So the government directly spends money on these subsidies, but they also directly spend money on healthcare expenditures. The $200 billion of subsidies that have gone to these less than healthy ventures directly lead to cardiometabolic disease, such as cardiovascular disease. But the healthcare cost of cardiovascular and cerebrovascular disease is over $350 billion. And we lose over 800,000 lives every year to this. Metabolic diseases, including diabetes and obesity, account for over $470 billion and almost 85,000 lives lost just from diabetes. If we take into account other preventable conditions such as cancer and Alzheimer's, which account for $174 billion and $215 billion respectively, we come out to $1.4 trillion every year and 1.7 million lives lost just from the top 10 causes of death. $1.4 trillion is 40% of our $3.5 trillion spent on healthcare costs. And the majority of this is stemming from unhealthy lifestyle practices, which are propagated by the $200 billion worth of subsidies going towards agricultural commodities that promote cardiometabolic disease. One major organization that plays a role in food policy is the USDA, which ensures a safe food supply, promotes the agricultural industry, but also gives dietary advice. Promoting the agricultural industry and giving dietary advice is a clear conflict of interest, because what the agricultural industry is creating is not necessarily what is healthiest. When you pair this with the advertising milieu we're in, with half of 1% of food companies' marketing dollars spent on fruits and vegetables, and nearly all of television food ads seen by children and adolescents being for products that are high in fat, sugar, and or sodium, it starts to make sense why it's so difficult to follow a healthy diet when there are extrinsic factors at play that influence you to make poor decisions from such a young age. So who takes responsibility for the American public having such a poor diet? If we look at large corporations that until now have not even been held accountable for their greenhouse gas emissions or their plastic and unrecyclable waste, we can't let them take responsibility for our health, even though they're the ones primarily distributing health information on packaging and media. Regardless, at the end of the day, those who are sick are going to end up coming to you, the medical provider. So it may not have been in your job description when you signed up for medical school, but you are going to be the point person for every single patient you see regarding health information. And this includes counseling on a good diet, high in fruits and vegetables, and a good exercise routine of 3.5 hours or more per week. So to summarize, what are all the different things we covered today as external factors that can influence someone's lifestyle choices? we covered food insecurity and home cooking, pollution and city planning, family and home influences, media and advertising, and finally society and policy. So what are some solutions in each of these sections? In terms of food insecurity, we can increase our funding for food and nutritional assistance programs such as SNAP, destigmatize food stamps, and create public policy and legislation to support families and improve food access. In terms of pollution and city planning, we saw that we could create and update cities to encourage walking around, and one way is to reduce pollution, increase the safety of pedestrians and maintain our public spaces, and accept food stamps at local farmers markets and fresh produce markets. In terms of family and home, we saw that parents and guardians are huge influences on their children in terms of healthy lifestyles, so we should support our families through school-based and community-based education programs, as well as financial packages to create time and resources to cook meals. We covered a lot in terms of media and advertising, but the general consensus is that we should pass legislation that restricts malicious and targeted advertising. Finally, in society and policy, we need to pass legislation that creates public initiatives to advertise and encourage consumption of healthy foods. We need to reroute our billions of dollars of subsidies from being the raw materials for unhealthy foods towards fruits and vegetables. Overall, we need to create a legislative culture that is centered around the well-being of the population. A lot of these solutions may seem very distant from your profession as a future physician, but there are things that you can do as well. As a physician, it is very important that you educate every patient that you see on a good diet, which is high in fruits and vegetables, as well as 3.5 hours or more per week of moderate to vigorous physical activity. But patient education doesn't stop there. You might see upwards of 20 to 25 new patients every day, and you can educate patients on lifestyle changes to help them improve their own health, but you can also inspire patients to improve the lifestyles of the people around them. And oftentimes, these patients can become change makers themselves and create policy and legislative change that can impact a larger population. That's why it's so important to provide this information for every patient you see. As a scientist, we still need to do a lot of research on the interconnections between those intrinsic and extrinsic factors that play a role in influencing someone's lifestyle behaviors. And as a physician, you will be a health authority, which means you can become an advocate by creating public initiatives in your community to encourage a healthy lifestyle, like Walk with the Doc. And you can also participate in policy creation and make these big scale changes that will end up affecting so many people. So I want to end this lecture by reminding all of you to have empathy towards your patient when it comes to their lifestyle behaviors. There are a lot of intrinsic and extrinsic factors at play when it comes to making a lifestyle decision, and patients are not always in control of the lifestyle behaviors that they follow. To reiterate one more time, we know that diseases are caused by poor behaviors, and if you ask the right question, you can figure out what your patient's obstacles are to those behaviors, and that takes you one step closer to helping that patient prevent disease and improve their health. Thank you so much for your attention, and I hope you got something out of this lecture on the social determinants of health and lifestyle medicine. Please feel free to reach out to me for anything at all, including questions about this lecture. My email is listed here. Thank you again.